Hi, this is Dr. Costello from the School of Nursing at the George Washington University, and I'm talking today on dementia, Alzheimer's, and others. I would like to offer a special thanks to Dr. Sandra Davis for her slides on Alzheimer's disease. What is dementia? Dementia is not a specific diagnosis, but a collection of symptoms. It's important to know what type of dementia has been diagnosed before recommending drug therapy. What are the risk factors for dementia? Advancing age. We know that 35% to 50% of people over 85 have dementia. Family history of AD or Parkinson's. Many factors overlap with cardiovascular risk factors: obesity, insulin resistance, vascular factors, dyslipidemia, hypertension, and inflammatory markers. Gender studies are inconclusive, and it may be that the disparity may simply reflect the women's higher life expectancy. AD and other dementias are more common in African Americans than whites, and nearly 100% of people with Downs who live into their 40s will develop AD. Traumatic brain injury is more prevalent today and is thought to the types of dementia include Alzheimer's disease, vascular dementia or multi-infarct dementia, Parkinson's disease dementia, Lewy body dementia, frontal lobe dementia, and modifiable causes of dementia. Uncommon causes are related to toxins, vitamin deficiencies, endocrine disturbances, chronic metabolic conditions and vasculopathies, structural abnormalities, and CNS infections. Alzheimer's disease is the most common cause of dementia. It is a terminal degenerative disease resulting in progressive cognitive and behavioral impairment. The expected cost for 2015 to all payers for the care of people living with Alzheimer's disease and other dementias is an estimated total of $226 billion. 60 to 80% of cases with dementia in older people are due to AD. There are no focal neurological signs on physical exam. It's characterized by memory loss, personality changes, global cognitive dysfunction, and functional impairment. Visual spatial disturbances are early findings. You'll find apraxia, aphasia, personality changes, depression, delusions, and hallucinations. It is the only cause of death in the top 10 in the U.S. which cannot be prevented, cured, or slowed. It is the 6th leading cause of death, and only 45% of people with AD or their caregivers report being told of their diagnosis. Vascular dementia or multi-infarct dementia. Onset of cognitive deficits are associated with a vascular event. There's an abrupt onset of symptoms with stepwise deterioration, and there are findings on neurological examination. Infarcts are seen with cerebral imaging. There's an overlap of AD and vascular dementia. Most patients previously categorized as either Alzheimer's type or vascular type probably have both. The likelihood of AD and vascular disease significantly increases with age, therefore the likelihood of both does as well. Vascular risk factors predispose patients to AD. Parkinson's is the diagnosis in which there's a coexistence of Parkinson's disease. Cell death in PDD is widely attributed to the development of Lewy bodies. Lewy bodies are proteins that clump together for an unknown reason and then deposit in neurons, causing cell damage and eventual cell death. Lewy body dementia is the second major most common cause of dementia. People affected by dementia with Lewy bodies often experience symptoms of delusions, hallucinations, and vivid dreams in which the patient may physically act out. These patients may have an extreme sensitivity to neuroleptic medications, and their use in this population can cause worsening cognition, heavy sedation, increased or possibly irreversible Parkinsonianism, or symptoms resembling potentially fatal neuroleptic malignant syndrome. In frontal lobe dementia, we get impairment of executive function, disinhibited behavior, and cognition testing may be normal with minimal or minimally abnormal. Memory loss is not a prominent early feature. Takes place in about 5 to 10% of cases of dementia and is an early onset dementia starting usually between the ages of 45 and 65. FLD may have the strongest genetic component of any of the common dementias. A useful mnemonic for reversible, modifiable causes of dementia. Delirium is characterized by the acute onset and fluctuating levels of consciousness, inattention, changes in cognition, perceptual disturbances over a period of hours to days with fluctuating daily course. Normal pressure hydrocephalus is characterized by a triad of symptoms. There's a particularly distinctive gait disturbance, urinary incontinence, and cognitive dysfunction. Diagnosis is initially made with neuroimaging. The Miller-Fisher test is an objective gait assessment before and after the removal of 30 to 50 mLs of CSF. If there is improvement in gait, then shunting can be a possible treatment. Cognitive decline with aging. What is normal aging? Mild changes in memory and rate of information processing occurs. It is not progressive and it does not interfere with daily function. Phases of dementia: mild cognitive impairment, early stage, middle stage, end stage. Mild cognitive impairment concerns the areas of judgment, language, and problem solving. There's more frequent memory loss, asking the same questions repeatedly, forgetting common words when speaking, mixing words up and misplacing items in inappropriate places, getting lost while walking or driving around familiar neighborhoods, becoming less able to follow directions. Patients can be evaluated with the Montreal Cognitive Assessment Performance Scale. The test and instructions for use of the test can be found in the clinical corner of this week's session. Treatment of MCI is to maximize functional performance, improve cognition, mood, and behavior. Non-pharmaceutical interventions such as physical activity, mental activity, and environmental adjustments to support memory. Early stage dementia begins with forgetfulness, which progresses to confusion and eventually disorientation. Poor problem solving, poor judgment, decision making is impaired. There are symptoms of depression, manic behavior, personality changes include irritability, agitation, sadness or depression, and manic episodes. Mid-stage is a progression from the earlier stage. Requirement of assistance with ADLs. Patients are unable to remember names and have loss of short-term recall. They may display increased psychological and behavioral changes. They may be physically or verbally aggressive. There will be poor personal hygiene and disturbed sleep, the inability to carry on a conversation. Patients become disoriented to time and place. They may ask questions repeatedly. In the late stage, there's loss of verbal articulation. There's loss of the ability to move around and walk independently. Bowel and bladder incontinence is a major problem. Extended sleep patterns occur. They are unresponsive to most stimuli. Patients who present with dementia will present with memory loss, apraxia, aphasia, delusions and visual hallucinations, disorientation to time and place, poor judgment, problems with abstract thinking, misplacing things, changes in mood or behavior, changes in personality and loss of initiative. Confounding factors with dementia include delirium, depression, a combination of the two, drugs, coexistent diseases, and psychosis. The mnemonic for differential diagnosis of delirium is I watch death. Making the diagnosis of dementia. Dementia is made frequently as a clinical diagnosis based on a comprehensive history and physical exam. Neuropsychological exams can provide more information. CT or MRI may be used to confirm a diagnosis or eliminate various possibilities. CT of the head is indicated if the person has experienced an acute decline, recent onset of symptoms, young age at onset, history of recent trauma, gait disturbances, or focal neurological changes. Full blood workup, including a CBC, CMP, thyroid function, B12 and folate levels, and syphilis test to determine if there are treatable disorders. Chest X-ray to rule out primary neoplasms and sarcoidosis in the chest. EEGs are used to confirm Creutzfeldt-Jakob disease and herpes simplex encephalitis. The mini mental state exam, or MSSE, 24 out of 30 score is suggestive of dementia. It has sensitivity of 87% and specificity of 82%. It is not sensitive for mild cognitive impairment, and it is spuriously low in people with low educational level, low socioeconomic class, poor language skills, illiteracy, and impaired vision. It is not sensitive for people with higher educational background. The tips for using your MMSE are to avoid the serial sevens and months backwards. Assess patient's literacy prior. Assess for dominant hand prior to handing paper over, and do not lead the patient. 3-item test repetition means that you repeat all 3, then have the patients repeat following. The 3-stage command, repeat all 3 parts of the command, and then have the patient go ahead and follow your orders, commands. Additional evaluation can be done with the clock drawing test, which has both sensitivity and specificity of 85%. And remember that the Montreal Cognitive Assessment is used for mild cognitive impairment. General treatment strategies. Define your symptoms clearly. Rule out other psychiatric illnesses. Rule out medical causes for the symptoms. Identify non-pharmacologic strategies, and then plan your pharmacotherapy. 2 classes of pharmacotherapeutic agents have recognized indications for the treatment of AD: cholinesterase inhibitors and NMDA receptor agonist. Tacrine is no longer widely used due to concerns about liver toxicity. All of the cholinesterase inhibitors are indicated for the treatment of mild to moderate AD, and Aricept is also indicated for use in severe AD. No clinically important differences among the drugs have been demonstrated. Namenda is more commonly prescribed in middle to late stages of dementia. Patients may use cholinesterase inhibitors and Namenda simultaneously. Nemzaric is a combination of 2 proven medications, Aricept and Namenda. It is used for patients with moderate to severe AD. These medications only slow the progression of dementia and AD. They do not stop or reverse the underlying disease process. Common side effects include nausea, diarrhea, and increased gastric acid secretion. Anorexia and the associated weight loss is a significant concern in this population. The Exelon patch can reduce nausea but may cause local skin irritation. Headache, muscle cramps, fatigue, insomnia, bradycardia, and dizziness with occasional syncope are also seen. The following classes of psychotropic medications have been used to treat the secondary symptoms of AD, such as depression, agitation, aggression, hallucinations, delusions, and sleep disorders. They include antidepressants, anxiolytics, anti-Parkinsonian agents, beta blockers, epileptic drugs, neuroleptics, NMDA antagonists, including Nuedexta. Nuedexta is a combination of dextromethorphan with quinidine and is indicated for the treatment of PBA or pseudobulbar affect, which manifests as involuntary, sudden, and frequent episodes of laughing and or crying. The management issues focus on alleviating patient distress, reducing the caregiver burden, delaying institutionalization, assuring patient safety. Patients, when in a comfortable and safe environment, often become more like themselves. For management, as the population continues to age, the prevalence of dementia increases. Diagnosing and managing the behavioral manifestations associated with patients with dementia is falling more and more to primary care providers. When the diagnosis is unclear, there are multiple confounding factors, or the patient presents at an early age, it is appropriate to refer to neurology or neuropsychology for further evaluation. Treat behavioral manifestations with appropriate medications and therapy. Maintain adequate nutrition and refer patients and families for counseling as is appropriate. There are behavioral problems in dementia, almost universally a problem at some point. Common problems include agitation, depression, delusions, and psychosis. Additional behavioral problems: disinhibition, apathy, personality changes, anxiety, wandering, and insomnia. Causes of behavioral problems: biological, due to the disease process itself; psychological, due to the loss of function and autonomy; socially, there may be family distress, economic issues, and family conflicts over care and property. Environmental causes include patients' increased sensitivity to change, and then, of course, issues of safety. Environmental strategies: identify the provocations and rectify if possible. Appropriately reorient patient. Optimize sensory input. Behavioral management strategies that respect the patient's need for control and autonomy. Optimize physical activity, social stimulation. Reminiscing is very popular and makes patients feel safe and secure. Agitation can occur as non-aggressive verbal and physical aggression. And then we have more aggressive verbal, which includes threats, name-calling, obscenities. Nonverbal aggressive behavior can be manifest by biting, scratching, spitting, kicking, pushing, swinging fists. The treatment of agitation and violence requires that provocative stimuli be identified and reduced. Optimize communication with the patient. Environmental modifications can be effective. For pharmacotherapy to work, you must target the underlying cause of the agitation and the violence. Depression occurs early in the course of dementia. The incidence is 40 to 50%. Use SSRIs first and avoid anticholinergic antidepressants. Remember that SSRIs can cause deleterious effects in people who have Lewy body dementia and PDD. ECT can be helpful, but may temporarily worsen cognitive symptoms. The treatment of depression: recognize that irritability and or apathy, withdrawal may be indicative of depression. Allow patients choice and control. Identify pleasurable activities. Cognitive enhancers may help. Consider Ritalin for apathy and poor appetite. Wandering behavior occurs in 4 to 26% of dementia patients in nursing homes. If not located within 24 hours, 46% will die. So the goal of treatment is necessarily patient safety. The Silver Alerts, or Safe Return, is a nationwide identification program where the alert system for law enforcement officials and TV stations is activated, similar to the Amber Alert for children. For treatment of wandering, lock the doors in a way that is confusing for AD patients but not others. Use wander guards. Decrease agitation. Make environmental changes that make the patient feel less agitated and less likely to wander. Sexually disinhibited behavior includes sexual talk, sexual acts, implied sex acts, false reporting. It occurs almost equally in men and women. Treatment of sexual aggression and/or disinhibition involves psychosocial reminders for patients. Move the patient to a private room. Clothing modifications can help the patient by making it more difficult for him or her to remove their clothing. Staff education is important and helps staff be more understanding of the patient's behavior. Pharmacological therapies, including anti-androgen therapies, have been found to be mildly effective. SSRIs may be effective because it reduces the obsessive component of the behavior. Define your target behaviors. Rule out delirium. Consider mood disorder, depression, mania, or psychosis. Review environmental factors. Review cognitive and sensory factors. Educate and support caregivers. Consider specific behavioral methods. Consider drug treatment. Involve other interested parties if necessary. Treatment of insomnia. Sleep hygiene. Treat the causative psychiatric or medical disorder. Physiological remedies, medications, and light therapy. Be sure with medications to avoid any of the anticholinergic medications. Caregivers should encourage independence for patients with dementia without sacrificing security. They can assist patients, but only if necessary. They must learn to compromise and develop ways to share activities. They also need to be encouraged to establish a support network and get other family members involved and other families involved. Educate themselves. There's a wonderful book called The 36-Hour Day, A Family Guide to Caring for People Who Have Alzheimer's Disease, Related Dementias, and Memory Loss. Encourage your family members and your caregivers to read this to increase their understanding. Recommendations on use of antipsychotic agents in dementia. Have a justifiable use and use for severe distressing psychotic symptoms. Do not use first line for non-psychotic behavioral disturbances. Use lowest amounts for shortest possible times. Caution patients and family about risk, but remember that older agents may be worse, and there is little data on other psychotropics to suggest that they are safe. Safety risks can be minimized through careful selection of appropriate patients for treatment, education of patients and surrogate decision makers, and close monitoring with understanding that for many patients short-term treatment is sufficient. Be certain to document your discussion of safety and the risks and benefits of therapy. And then we return back to primary prevention. Remind families and patients as you go through your day for them to be physically and socially active. Control blood pressure, homocysteine and cholesterol levels, control diabetes, maintain a healthy diet and with healthy weight. Keep the mind active, stop smoking, and moderate alcohol intake. Thank you for listening.